dear Professor. Now I know it's getting late. I will try to be as short as possible. When I got the invitation to take part of this interesting meeting, I saw the program, I saw the participants, I said to myself to give you a complex and successful case, it will be difficult. I will not get interested in that. So I said to myself, what about a simple case, but with a very bad outcome, eventually? So simple case, 76 years old, aortic stenosis, symptomatic, a lot of other problems, post-cabbage, chronic kidney failure. STS score was high, Louros score 13.6, so obvious. It's a TAVR. Standard procedures, we did it last year in June. An Evolut Pro 29, femoral access went well, not single problem. Couple of days after the procedure, we let it go. We let the patient go. He came back, 10 days out of discharge. Pulmonary edema, fever, anemia. TAVR looked okay on the echo, but blood culture was positive for Enterococcus faecalis. So we started him on antibiotic therapy. Couple of weeks, he stabilized, everything came back to normal. We let him go. Again, 4 days after procedures, after the second discharge. Same story again. The valve looked good. Again, blood culture were positive. This time it was 6 weeks of antibiotics until we stabilized the patient. And, well, third time's a charm, I say. Blood culture were positive, he came back again. The echo was not that normal at that time, so I'm going to show the echo. Guess for yourself. We repeated 2 weeks after. More obvious than that, it's evident. So the patient died a couple of days after a cerebral embolic event. Pretty obvious. Now, since 2002 that we've started to implant TAVIs, we are becoming very good in solving technical issues. Kind of access. We're going lower and more hydrophilic and everything. We do cerebral protection. We're good with paravalvular leaks. We can implant in small valvular sizes. We know how to treat an AV block. We can prevent it. We do commissural alignment. We have larger cells for future access of the coronaries. We do wonders. We even put valve in pure AR. Sizing is not a problem. Some companies have up to 10 different sizes, and cost availability, that's not a problem either. I mean, you can see the equivalent of Edwards, it's the MyVal from India, and you can see the other equivalent of Medtronic is the Venus from China. You do have everything. We have adapted to fix technical complication. We are adapted with a technical advances. Now, just to show you, just to prove you that, it's a 3-year-old, it's my nephew. He did all that in less than 1 minute. The technicality is not a problem for us. The advances, these are not a problem. However, endocarditis still remains a problem. It was a problem, it's still a problem. Same mortality as the standard surgery, but at least 3 times more frequent after TAVR than after standard surgery. And that's one of the points why we cannot implant TAVRs in young patients with low surgical risk. That's the single point that surgeons are holding us, where they are not allowing us to implant TAVRs in those patients. Second problem, we have more and more resistant bacteria. So, in my humble opinion, the endocarditis will be our next challenge, not the technical one. Thanks for the attention. Keep it short.
Thank you, excellent. No one of us want to be in your position. And actually, we have no solution for that. Professor Louros, any comment? You are muted.
No, I'm not.
Okay.
Can you hear me now?
Yeah.
Good evening to everybody. Thank you for the kind invitation. It was a very interesting case, and indeed, this is going to be a challenge in the future. Although I have to comment that we all know, all of us are interventional cardiologists, and our colleagues, arrhythmiologists as well, know that infections in the perioperative time frame, are related to the invasive procedure itself. So what we need to do at the moment is to be very careful, sterilize the cath lab, and of course be very careful with vena punctures, with the insertion of sheaths for temporary pacemakers, and do the least invasive procedures apart from the main procedure, the TAVI, the least invasive procedure we can do. For example, in our center, we try to pace during the implantation of TAVI through the wire, through the guide wire, and avoiding inserting a venous sheath in the jugular vein or in the femoral vein, etc. The second issue is that, and it was beautifully shown, is that we have a resistance to the antibiotics, and I hope our colleagues, the infectious disease doctors, are going to be helpful in providing new therapies for resistant microbes that unfortunately are very common in large hospitals.
Let's hope so.
Any other comments? Do you find any source for the Enterococcus, I think?
No, we don't know. It's not the first case. It's the third case we've had in 3 different patients, 3 different centers that arrived. The issue, in my opinion, if I may, we're considering TAVR as a non-invasive, a very less invasive procedure considered to open heart surgery. And we are lowering our guard sometimes. So it's time to consider it. It can be risky, it can be dangerous, because it's a conundrum to tell a patient, we put in your TAVI to avoid your surgery, and then you have an endocarditis, you have to go back to surgery. It doesn't really make sense.
Do you use, in any case, antibiotic prophylaxis before TAVI?
Yeah, by definition.
And after that?
Yeah.
So, Dr. Chrysogeris, yes.
We see occasionally endocarditis, and indeed it's a very difficult situation. Thankfully, we've been able to, in 2 or 3 cases that we've had with antibiotics, they were corrected. Do you think the mentality of the interventional cardiologist compared to the surgeon is a bit different in terms of antisepsis and prevention? Because, you know, the surgeons are very strict with their antisepsis and everything else. Do you think it's a matter of
all right, excellent point. I mean, I remember when I started my internship in year 2000, more or less, that the surgeons, before starting surgery, before sending a patient to surgery, they were not that concerned about anesthesia or things like that. They are concerned for the patient to go to the dentist, to fix everything, to go to a doctor, to look for entry points. So at the time, they were extremely serious. The patient had no chance to go to the operation room without solving every possible point of entry for infection. Now we're considering the patient kind of, our procedure are considered kind of not that invasive, but a valve is a valve. So we are lowering our guard. That's what I'm trying to say, very probably. So shame on us.
Any other question? If not, just a last reminder that in endocarditis instructions for prophylaxis before TAVI, we have to check for Staphylococcus and treatment before implant. In this case, it was not Staphylococcus.
No, it was Enterococcus, but...
Okay.
Right.
Thank you very much for presentation, and we move